Managed Care Contracting today. I'm Andy Cleek, and I am the co-director of the Managed Care Technical Assistance Center, and I want to welcome all of you today to what will hopefully be a really informative webinar. A couple just kind of logistical issues before we get started. Today is really designed to give you a very broad overview, but we really kind of designed this as a follow-up to the in-person trainings that we've done with Adam Falcone over the last several months. So I'm hoping that many of you have been part of those trainings. The slides of those trainings and a full videotape training of those trainings is actually up on our website at MCTAC.org. So if you weren't part of those trainings, please feel free to take advantage of those of the video, or if you have additional questions or you want to Adam refers to something you want to look at a little more detail on that. Today we really are going to focus on Q&A. So Adam is going to give us a broad overview of some of the work that he's done in those trainings, but then we're going to really dive into Q&A. So I want to strongly encourage people today to use the chat function. There's a chat function and a Q&A function in our webinar, but we're going to try to use the chat primarily. So please use the chat function, and as we go along, if you have pre-existing questions that you came today with, please just chat those into the chat function now, or as we go through the webinar, we're going to make a running list. And then if Adam says something that sparks a question today, please put that into the chat function as well. And again, we'll add that to the running list. So don't feel the need to wait until the end to chat in your questions. Feel free to chat them in now or as we go through the process. If you have any technical issues as we move forward, please chat them into the chat function, and Amanda, who's in the background coordinating all of this, will do her best to kind of answer those questions. Also, Amanda just put in the chat box the link to the online recording of the Albany contracting event. So you can take that link and cut and paste it into your browser if you ever want to take a look at that. Everything we do today will be recorded, and we'll put it up on our website. If you have policy level questions, Adam obviously is not an OMH or OASAS employee, so he can't really address the policy level, New York State policy level questions. So if you have those questions, send them in to us. We actually have a running list of policy questions around contracting that we've shared with OMH and OASAS, and we'll add that to that list. So those are kind of the logistical issues. We're on from 10 until 12, but we'll the webinar will kind of go until we run out of questions. And so we might wrap up a little early, but certainly by 12 we'll be done. So just before we hand the microphone over to Adam, I'm going to just give a little bit of an update just in terms of where we are with the Managed Care Technical Assistance Center, or MCTAC, and then we'll get moving on to Adam. So if this is your first encounter with us, MCTAC is a training and consultation and educational resource designed for all mental health and substance use providers in New York State. So if you are an OASAS provider or an OMH provider in New York State, then we've been asked by New York State Office of Mental Health and the Office of Substance Abuse and Alcohol Services to work closely with all of you to really help you make the transition to Medicaid managed care. As you all know, the dates of that have moved around a little bit, but we're really on top of all of that and going to work really, really closely with everybody to make sure that they are as ready as possible for that transition. We provide foundational information to prepare providers for managed care, just like we're doing today around contracting. We're also working on a number of tools in the background. We just published last week, we published all the frequently asked questions for our kickoff forms that we did, so those are available on our website, MCTAC.org. And in addition to that, we're working on a glossary that's going to be coming out in the next couple of weeks that's really going to lay out for people exactly all just the different terms and acronyms and everything we've all, we go to every kind of training comes with a new set of acronyms. So we're working on that in the background. And then we are also very closely working with providers to develop training to really cut across these kind of critical domain areas. So some of the things that we'll be announcing soon and to keep a real close eye out for are a whole series on revenue cycle management and billing, a whole series on utilization management, and a whole series on evaluation, kind of building from outcomes from the foundation on up. So please keep an eye out for those. And then one other thing, we also really work very closely to aggregate the feedback we get and give that back to the state in order to kind of provide them with support and an understanding of kind of where providers are. But just to be very clear, we never share anybody's individual information with anybody. So if you complete our readiness assessment or through one of our projects, you give us, information about kind of where your agency stands. That information stays with us and doesn't get shared back with others. We're a consortium of a number of partners, including the McSilver Institute at NYU, where I work, the Ideas Center at NYU School of Medicine, CCSI, MSO consulting firm upstate, Administrative Services Organization upstate, Institute for Community Living, a large provider in New York City, NIAPRIS, and Casa Columbia, who really works closely with us on particularly tailoring services for substance use providers. We've hosted a number of these in-person events upstate with Adam. We did 5 of them. I think we had more than 600 people show up. Again, that whole event is online if you haven't been available, if you weren't able to come. And then we also hosted contracting from a managed care perspective. We had one of the plan lawyers, Harold Islin, come on and really talk us through the plan perspective. That's also available on our website at MCTAC.org. And then there's a polling question that's up and available. We just want to get a sense of who's been with us for the in-person events and who hasn't. So if you could just answer that poll question real quick. Amanda will leave it up for another 15 or 20 seconds. The question is very simple. Did you attend an in-person contracting event, yes or no? So I'll give folks just a minute to answer that question, and then we'll get going. All right, Amanda, why don't we close the polling question, which I think you did, and we'll wait for the results. Okay. So it looks like about 40 of the folks, 50 of the folks had been to one of the contracting events. About 70 had not, so we got a little bit more of folks who had not been to one of the contracting events. So you'll get a good overview today, and then feel free afterwards to take advantage of the web-based training that's available and on our website. Just a little advertising for an upcoming event. So for many of you, we've asked that you complete a readiness assessment, and actually you can still complete the readiness assessment if you haven't already done so. We strongly recommend that you do that. But we have scored all the readiness assessments that we have gotten back, and we got more than 300 readiness assessments from throughout the state, really evenly split between substance use providers and mental health providers. We are going to do a webinar on February 26th. I believe the notice went out the last couple of days. Please sign up for that webinar. We're going to give an overview of the results of that readiness assessment, looking at agencies who are already billing managed care versus those who aren't, agencies that are larger versus smaller, kind of a regional breakdown of agencies, OMH agencies versus non-OMH agencies. It'll really give you a good idea of kind of where you stand compared to providers around the state, and also give an overview of where providers are around the state in terms of their readiness for managed care. Again, that webinar is going to be on the 26th from 10 to 12, and for those 300 providers that have already turned in an assessment, right after that webinar, you're going to get a standardized, individualized report for your agency letting you know exactly where you are compared to others around the state. So you'll get an individual report with some recommendations and then highlighting kind of where you are against compared to providers around the state. So if you haven't completed the readiness assessment, I strongly encourage you to do so now. It's available at the MCTAC.org/provider readiness. The website link is down at the bottom of this page. Go on there, fill that out, and get that turned in. We will turn additional webinars back to providers. Any folks who continue to turn in the readiness assessment will get an individualized report back, so we strongly recommend that you do that. It really is a good model for really getting a sense of kind of where you are, not only in comparison to others, but kind of to lay out a roadmap of what your agency is going to need to do to be prepared for managed care. So again, we strongly recommend that. If you're a kids provider, and there's an addendum for kids, specifically designed for kids providers. That's going to be part of that. So if you don't know anything about the readiness assessment, sign up for the webinar and then complete it. And if you've already completed it, please sign up and get a sense of kind of how the rest of the state did and where the state is. And then right after the webinar, you'll get your individualized report, which we're really excited about. Also, just to highlight, we've launched a new website, MCTAC.org. And so please feel free to visit our website. It has all of our trainings. This webinar and all of our other trainings are posted on that website. Useful links are posted on that website. The readiness assessment is on that website. So please visit MCTAC.org for all of your kind of MCTAC needs. You can also, if you have questions, there's a link on the website as well, but also if you have questions, you can go to mctac.info@nyu.edu and we'll get back to you. It takes about a week or so for us to get back to more complicated questions. Simpler questions, you get right back. But more complicated questions, it takes a little while because we actually have a structure set up to answer some of those more complicated questions. And then also we're on Twitter at CTAC-NY, and we are posting many of our events on Twitter when they become live, those kinds of things. We do a little live tweeting. Sometimes it's from some of our events, but we post major announcements on Twitter as well. So if you're on Twitter, please feel free to follow us there. Adam Falcone is a partner in Feldesman, Tucker, Leifer, and Fidel, and has been our contracting consultant in this process and has done 5 of these live events around the state, and we are incredibly pleased with the response we've gotten to these events, and we're really, really pleased to have Adam here today to really give an overview of some of that work and then take questions. So before I pass it on to Adam, just one more final time to just highlight that as we go to please chat your questions, and we're going to keep a running list and then start asking those questions before we start. And with that, I'm going to pass it on to Adam, and he's going to take it from here. So Adam, you should have the ball now.
Great. Thank you, Andrew. And thanks to the MCTAC folks for setting up this last and final webinar. As I've mentioned to people who are not in New York State, they're not as lucky as you to have all the breadth of resources that the state of New York has made available to you through the Managed Care Technical Assistance Center. I wanted to thank you again for those of you who have attended the in-person trainings to coming back here for this summary and office hours to ask additional questions. Those of you who have attended the in-person trainings will see that the slide deck that you have today is a little bit different than the one that you received at the training. This is a much more condensed version, but it also includes some what I think are handy appendices in the back of the slide deck. I think similar to those of you who know that all the good stuff is at the end of the managed care contract, the same is true for your slide deck here today, in which Appendix A for your slide deck has key questions that you can use to evaluate your contracts. It's called Contract Review. And then Appendix B at the back of the slide deck are key RFQ provisions, requirements that are imposed upon the Medicaid plans in New York, and key provisions that I repeatedly received a lot of questions about, and that I think would be most helpful for you in reviewing contracts, and that I'll probably refer to today as well. As I mentioned at the in-person trainings, I'm not an employee of the McSilver Institute at NYU or any state of New York agency like OMH or OASAS, and I'm also here just providing educational information. This is not intended to create an attorney-client relationship. And then one last note, as Andy mentioned, you can please add your questions as they occur to you in the chat box. You don't need to wait to the end to do it. So those of you that attended the in-person trainings know that I set out a formula or model for you to use in thinking about how to contract with the Medicaid managed care companies. My clever acronym, PEN, before you sign, use the PEN, basically dividing up the contracting efforts into 3 distinct phases. The first being a preparation phase, the second being an evaluation phase for evaluating the contract, and the third for a negotiation phase. And you may not use all 3 elements every time you receive a managed care contract. Perhaps you'll do it, with the first contract that you receive, and then apply what you learn from that effort to subsequent contracts. So I'm going to summarize and give some of the highlights for contracting and how to use this process, and then after that we'll open it up to questions. As I mentioned at the training, the most important phase, in my view, is really the preparation phase, where you think about what advantages you have and what strengths you have. At the in-person trainings, I noted Malcolm Gladwell's book, David and Goliath, where he talks about the ancient battle between the two and how David is the giant who's perceived to have enormous strengths over David, but somehow miraculously David won the battle. And Malcolm Gladwell's take is that's all wrong, and it doesn't acknowledge the strengths that David actually had. That he had a very powerful weapon in his hand, that slingshot, that was essentially equivalent to a gunshot, and this big hulking giant was no match for that kind of weapon. He was not expecting it, and he didn't know how to deal with it, and obviously did not prevail. So I think many of us think of the managed care company as also as a giant. So it's incredibly helpful to think about what advantages or what strengths you have in the contracting process, because the managed care company is not going to tell you. You have to do this work a little bit yourself. So in the trainings I discussed about identifying your strengths going through sort of 3 separate processes in this phase. First, thinking about how to assess what leverage you have in approaching the contracts. Second, thinking about ways that you can compete with other organizations based on the value that you provide. And then third, thinking about ways to increase your leverage or your value if you're not pleased sort of with the leverage that you have right now, or you're not able to really compete in value in the way you want, ways that you might consider for the future of changing that dynamic so that you do have additional leverage and you can compete. So the first step in assessing your leverage really focuses on your regulatory strengths and thinking about whether the plan is required to contract with you, whether they're required to cover one or more of your services, and whether they're required to pay you any specific rate. And here, information really is power. And in order to gain that power and use that strength, you have to be knowledgeable about what the obligations are on the managed care entity. You have several sources to turn to in any contracting situation, whether it's with Medicaid MCOs, commercial MCOs, or otherwise. Your state has a lot of laws and regulations that apply. Insurance is a state-regulated activity, so it starts with your state insurance laws, which govern network adequacy requirements and the such for commercial contracts. You have Medicaid laws and regulations, and then, of course, the most important documents are really the MCO's contract with the state Medicaid agency. New York is a very transparent state, and you're able to actually access the contract, which is the RFP, that binds each of the managed care entities to the state of New York and sets out what their contractual obligations are. I've included here links to the RFQ for behavioral health. There's also key provisions in Appendix B of these slides. And the second document is actually a link to the mainstream managed care contracts between the state of New York and the Medicaid managed care entities, because there is some reference in the behavioral health RFQ to the main Medicaid managed care contract, and all those terms are also applicable to your contracts. Lastly, if there's state exchanges, there's rules and regulations that typically go along with that. So in regard to whether the managed care company is required to contract with you and what rates they are mandated to pay you, this is where it would be really very helpful to look at Appendix B after this presentation. Look particularly on slides 38 and 39. 38 reviews the contracting requirements. For example, it says that if you currently serve 5 or more Medicaid managed care enrollees, the plan must contract with all OMH and OASAS licensed or certified providers, and for a minimum of 24 months. It runs through some of the other types of providers in the mental health and substance abuse area and what the requirements are there as well. Obviously, they're very generous, at least particularly in the first 24 months, to ensure that the transition to managed care doesn't create access issues for individuals and consumers for accessing these types of services. Slide 39 reviews the payment requirements and specifies, for example, that all OMH and OASAS licensed and certified providers have to be paid no less than the Medicaid fee-for-service rates. So for many of you, the APG rates that New York requires. that gives you a lot of leverage in these managed care contracts and the negotiations, because it takes some things right off the table. You don't have to worry about getting the same amount that you received under the Medicaid program. You're guaranteed that rate, and then there's certain services that are obligated to be provided, and contracts are mandatory with certain types of providers. So this should give you a lot of strength and understanding what these obligations are, the MCO, and improve your leverage in these discussions. The second aspect to consider in assessing your leverage really is market-based. Those of you know that in any market where you have market power, you can exact price control. You have a lot of leverage in those conversations, as well as in the other provisions in the agreement. The reimbursement rates are not the only item in these managed care contracts. There are a lot of other additional requirements that relate to how long a plan has to recoup what they think are overpayments from you. There's provisions that relate to credentialing with utilization review. Obviously, if they deny authorization for a service, you're not going to get paid. So even if you have a guaranteed rate, if you're not going to get paid because it wasn't authorized, then it does you absolutely no good. So don't lose sight of the fact that there are many, many provisions in these Medicaid managed care contracts, and many of them do affect your rates and whether you get paid at the end of the day. They do have financial and operational implications for you as well. So in assessing your market leverage, think about whether the MCO has alternatives if they don't contract with you. Are there other entities within your county that provides the same or similar services? What percentage of the market do I have in those counties, in those areas? And obviously, the fewer providers, the greater leverage you will have, because if the plan has to contract with you because you're the only game in town, or if after 24 months they have to contract with at least two of your type of entity within every county, and there's only two of you, then you should be each getting a contract and not competing against each other. The third aspect is to consider timing issues, because timing can also make a difference in what kind of terms you can obtain from the managed care entity. If they're under strict deadlines for proving to the state, for example, that they have made their network adequacy requirements, that they satisfy those requirements, and there's a deadline that they have to submit information to a state, and they're not quite there yet, then clearly you have the upper hand here because they need you at this time, maybe more than you need them. How do you get answers for figuring out those matters? Of course, you can look at the RFQ because that has some information in it, but you can ask questions as well in the negotiations process. If the managed care company says you need to turn around and sign this contract within a week, you're free to ask them, why do you need it within a week? And they may share information with you that is helpful for you to know whether they're under a time crunch or not. I also encourage you to talk to your trade and professional associations who are actively trying to assist you in this process and may have access to information that could inform the timing issue, as well as your peers who may also know some information about whether MCOs are under certain obligations. The next phase of assessing leverage is to think about competing on value. New York State obviously has made a very significant push to push providers into a value-based payment model. You see it at the state level. You also see it at the federal level. Secretary Burrow mentioned in a speech not long ago, maybe a week ago, that they hope to move to value-based payments to something on the order of 75% of all Medicare payments by 2016, I believe it is. So there's a gigantic push for providers to not just be paid on value, but really to be competing on value, so that not all providers necessarily receive the same amount of reimbursement, but those that provide greater value would receive higher reimbursement and are rewarded and incentivized. So in this process, it's helpful to think about three distinct phases as well: identifying what value you bring to the table, thinking about how to assess that value and to quantify it, and then third, how to communicate that value to plans. So the self-assessment questions you should think about here is whether you offer and how you can offer potential cost savings to the MCO. Remember that the MCO gets a fixed amount every month to take care of all the patients that are enrolled in their plan. they have a limited amount of dollars to work with. And so if you can offer them ways that can result in reductions in ER visits, which are very expensive, or inpatient hospital admissions through greater adherence to antipsychotic medications or better management of behavioral health or substance use disorders, or even identification of undiagnosed behavioral health or substance use issues in patient populations, that can be very beneficial to a plan. Not only because it can save them money down the line by avoiding expensive hospitalizations, but also they're rewarded and incentivized by the state. As you'll see in one of the appendices in slide 50, there are quality incentives where plans will have a withhold, particularly the HARP plans. These plans will have a 1, 2, or 2% withhold. That means the state holds back money, and they have to earn it back by meeting certain quality benchmarks. If you can help them meet those benchmarks because you have quality outcomes measures that you can show the plan, or there's a process measures that you can demonstrate the plan that you can help them meet those measures and qualify for these additional incentives, that will be attractive to a plan. They want to earn this money, and if you can show them that they can through contracting with you, you're providing additional value to them, not just completing their network requirements, but actually resulting in additional dollars on the table. Another push nowadays is to understand the total cost of care for patients, so not just for the patient's behavioral health costs or substance use disorder costs, but their total cost of care, the cost of care on the physical health side as well, and managing those costs and making sure that patients get coordinated care between the physical health and behavioral health needs that they have. If you can access that information from a plan so that they can inform you, for example, when the patient's gone into the hospital or whether they've gone in for appointments with their primary care doctor, or this helps the plan because ideally it would help manage their total cost of care. As you also know, there's a huge push right now for integrated models of care that bring primary care and behavioral health care together. The beneficiaries of cost and Medicaid program the most, and the managed care program the most, are individuals who have comorbid chronic conditions and mental illness. Those costs are 60 to 75% higher than those with just chronic conditions alone, but without mental illness. And costs for those that have substance use disorders are nearly 3 times higher. Because you serve these patients, you are serving essentially the patients that have the highest cost in the system. And to the extent that you can coordinate their primary care and make sure that that care is getting adequately addressed, then you have the potential to save an enormous amount of money to the plans as well as to the state. And so these integrated care models are something that the plans are going to be very much looking for because they know that there are demonstrated outcomes. There's evidence that this saves money by providing integrated care models. Lastly, think about how you might be able to compete on value against other providers by being willing to incur some downside financial risk. Downside financial risk means that a plan has downstreamed some of their financial risk to providers, which they're allowed to do in limited quantities under New York state law. And so, for example, when a plan pays an IPA or pays a provider in a capitated manner, then essentially they're giving you a fixed amount of payment to provide a range of services, and they don't have to pay you any more, even if you provide more services, have more patients, more services than you expect to. It's all a set, fixed in advance, payment paid in advance rate. The same is true for bundled payments or case rates that pay for specific diagnoses or conditions. The plan pays you a fixed amount, and that's all you're going to get. Plans also have been entering shared savings arrangements with ACOs, with IPAs, and in some cases with providers directly. This also incentivizes the provider to manage the total cost of care, and that's also attractive to plans as well, because again, they're downstreaming some of their financial risk to the providers. Now, this won't be a way that you want to get paid for all providers out there. You do need to have the financial ability, the capacity, the internal resources in order to manage downside financial risk, or when you get paid on a capitated model. If you don't have those abilities right now, then that might be something that you want to work forward to in the next couple of years, and is obtaining that ability to manage financial risk. Lastly, you have to be able to communicate the value back to the plans. You may know the value that you bring. You may have evidence of all the outcomes based on quality measures that you're using to evaluate the quality of care. That doesn't necessarily the managed care company, the managed care company knows that. They may look at you and similar providers of services as all the same. You need to distinguish yourself, just like products in the marketplace do that for any other product that's out there. Think about the toothpaste options you have when you go to the store. You're overwhelmed with a dizzying array of choices, but many of those companies, whether it's Crest or any other brand, they distinguish themselves by saying, they do have extra teeth whitening, or they can help provide for sensitive teeth. So they have distinguished their product and communicated with the consumer the extra value that they have and how they're different from other types of toothpaste brands. The same holds true in this new managed care marketplace. It is a marketplace with buyers and sellers. The plans are buying your services and you're selling them. You need to be able to communicate the value that you bring. So if you meet certain clinical quality benchmarks, you should be able to express those and explain those to the plans and explain how it provides greater value when they contract with you as opposed to somebody else. Or if you can save them money by them paying you in a different way than they're proposing, you have to be able to quantify that. But if you can show them that down the line it leads to a reduction in the total cost of care, then that could be something attractive. How do you talk to the plan? Well, many of the plans will participate in conferences, which is an opportunity to engage the plans in conversations. There's informal network events, community events, but don't hesitate to reach out to the plan directly. And the plan's contracting representative may not be the person that you want to reach out to. Each of the plans under the New York State RFQ are required to have a behavioral health medical director and a behavioral health clinical director. It may make more sense for your clinical director to reach out to their clinical director and talk about the additional value that you bring, or talk about how you are hitting and meeting or exceeding certain quality benchmarks so that they know who you are and the value that you bring to the plan. And maybe the plan is going to take an extra interest in including you in panels or in advisory committees for how they design their quality projects that are mandated to conduct by the state. That will give you an opportunity to, again, showcase the skills that you bring, have an ally inside the plan, and can result in better contracts with the plan as well. If you're not pleased with the leverage you have currently or the ability to compete in the marketplace against other similar providers, then you might want to be looking at ways to engage in collaborations, either with other providers through joint ventures and integrated provider networks, or other models where you integrate with other different types of providers. And I just want to highlight a couple of these models. For the integrated care models that bring primary care and behavioral health providers together, there are many types of joint ventures that providers have pursued in order to link their care and to provide coordinated care in a more integrated method. From the most basic model of referral agreements, where primary care and behavioral health providers have referral agreements so that they refer patients to each other, as well as to co-location agreements where they're actually side by side. They're separate autonomous entities, but they're in a physical structure where they share a location to make it easier for them to share and coordinate care and to pass off patients from one to the other. There are also arrangements where you have purchase of services or purchases of capacity. So primary care providers who lack the behavioral health practitioners buying those services, leasing those services and that staff from the behavioral health provider, and those practitioners coming over to the site of the primary care provider to provide those services. It also works in the other direction, where the behavioral health provider may purchase services from the primary care provider, and then those primary care practitioners come over to the actual service site of the behavioral health provider. The most integrated model, of course, is the merger context, where primary care providers and behavioral health providers merge into the same corporate entity. There are also a variety of provider networks that are being pursued by many providers throughout the state. Some of these are independent practice associations that bring together different types of providers under one provider network. In some cases, you have behavioral health organizations, or BHOs, which are collections of behavioral health providers into a formal network. And then the third option I see a lot is managed service organizations, where providers come together to provide some of the back office services to each other and to assist in some of the billing activities and credentialing activities so that they don't have to do those by themselves. You're probably all familiar with the DSRIP program and the performance provider systems in New York, which are essentially, PPSs are essentially networks of providers. Same thing is true for accountable care organizations. ACOs are also a type of provider networks. Provider networks go by many different names: IPAs, ACOs, PPSs, BHOs, MSOs. At the end of the day, it's all a type of provider network, and that's the most important thing to think about. Some of them do different types of activities, but they are networks of providers working together. And there's many different types of networks that providers come together to pursue. Some on the slide you can see the shared support services, in which they just share some of the back office functions that they don't want to do by themselves and then provide those services at cost to members of the network. It can be basic things like helping to maintain their electronic medical record or sharing an electronic medical record, becoming an HIE, a health information exchange, having the network engage in the credentialing activities with the managed care companies or credentialing practitioners, debarment checks, third-party billing. There's a whole array of back office support services that some MSO networks do on behalf of their members. At the other end of the spectrum, some networks actually do engage in managed care contracting. Some might market the network of providers to managed care companies. Others might facilitate some of those managed care contracting efforts through using a messenger model, where the plan messages a model to the network, and the network then messages that model down to each of the individual providers, asking them whether they want to accept or reject those terms. In the messenger model, the managed care entity, the network can't negotiate the terms, but they can provide objective information to each of the providers about the basic terms of that contract, what those terms are. They can provide a summary of terms, and then they can convey information back to the plan about what percentage of the providers in the network accept those terms. Networks that are clinically or financially integrated are able to actually negotiate contracts, capitated risk contracts between networks and plans, capitated arrangements. Those count as financially integrated arrangements, and the network can negotiate those contracts. Some networks don't negotiate the underlying payment rates, but they do negotiate shared savings arrangements. Similar to the model in the Medicare ACO program, where the ACO has an agreement with CMS for shared savings. The providers don't get paid through the network. They continue to bill Medicare individually, but if there's shared savings, that money comes to the network and then is distributed to the participants in the ACO. So there are lots of variations for these models for managed care contracting and shared support services, but at the end of the day, it's about providers working together, coming together, forming a network so that they're stronger and can have greater capacities collectively than they would on their own. As a former antitrust lawyer at the DOJ, I have to just warn you that you have to be careful about the antitrust risks. The antitrust laws, both your state and your federal antitrust laws, they view individual providers as competitors. And just like you wouldn't want the airlines talking to each other about how to set their fares, or gas companies talking about how much to set gas prices at, the same is true for any other service in our marketplace. So if providers come together and they talk together about how much a plan is offering, that raises an issue under the antitrust laws. You may have been able to talk about what rates the state pays you when the state is paying you, and you may be able to lobby together to a state because you can do that. That's lawful. But when you move to Medicaid managed care and you now have a private entity that is setting payment rates to you, then the antitrust laws basically come up. Providers no longer can discuss together, can negotiate together collectively with the plans unless they're clinically or financially integrated. So be very aware about the antitrust laws and how they apply to you, and may restrict what you do collectively. The second phase in evaluating managed care contracts is the evaluation phase. In this case, I proposed a strategy for what you could use to evaluate specific contracts. Strategy is just a fancy way for a plan. So I wanted to run through and highlight the 6 or 7 elements for reviewing contracts and evaluating them. The first element is to consider the time frame that you have. has a plan set a deadline for when you have to turn around and provide this signed contract or negotiate with them. Consider that in developing your evaluating the contract. Second, think about your team within your organization. Who's going to review the contract, or are a few of you going to review the contract? You know, it's essentially divvying it up between different people who have different responsibilities in the organization. Who will be your point person? Who is going to be the person that actually negotiates directly with the managed care contracting representative? Doesn't need to be your CEO. It could be somebody else within your organization. But I do encourage you to have one person that consistently negotiates these managed care contracts. They will learn a lot in the process about how to negotiate with the plan, what to say, what maybe not to say, and they can use that experience and build upon it with each subsequent managed care company that they negotiate with. So do try to keep it as one person throughout the who's negotiating all your contracts, as well as if any issues come up during the contract term, you should use that person to go back to the plan and the contracting representative, if you can, to address those issues. If you've developed a relationship with them in negotiating the contract, certainly you should be able to call upon that relationship if you have issues. In the same way, if you have an issue with your car insurance, you might go back to your insurance agent to help you. You should be consider doing that the same thing if you have a contracting issue during the course of the agreement. You want to make sure that you assemble all the documents that you need to evaluate the contract. Here you should not assume that the plan knows the scope of services. They may very well not know that you provide, outpatient clinic services. Maybe they just think you provide one of these behavioral health types of services, but not the full array. So you want to make sure, since you want to get paid for all the services that you do provide, you want to make sure that the contract adequately reflects all the services that you intend to contract for, and that you have the right type of agreement. I've heard recently from many organizations that they are not getting, facility or agency agreements. They're getting individual contracts for their practitioners. If you're an agency or an organization, you should be receiving a facility agreement, which allows you as a facility to bind all the practitioners that you employ or contract with, and this would be the agreement that you have with the managed care company. So make sure you do have the right contract for the right scope of services, and that you have all the exhibits and appendices that are referred to in that managed care contract. Fourth, you may want to think about assessing the MCO's operational performance, whether they are a plan that makes their payment obligations on time, whether they've had issues with other providers in credentialing and getting your practitioners credentialed in a timely way, whether they've been responsive to any requests you've made. If you don't have direct experience with the plan, then this is one situation where you might want to talk to your professional or trade association to see if they have any insight on the plan's reputation, or other providers who currently contract with them. Ask them how easy they are to deal with. If they are a difficult plan to deal with, then it might give you pause to think about whether you need to contract with them or want to contract with them, or whether you want to have some additional contract terms built into your contract to address some of the issues that other providers have had. Lastly, consider the MCO's financial stability, because if an MCO is not financially in a good position and they go bankrupt or they are insolvent, they're not going to pay your claims, or you're only going to get pennies on the dollars. So you want a strong, financially secure plan that has money to pay their claims, so that you're not left hanging. 6 is actually reviewing the contract itself. And in Appendix A of these slides, I actually have questions that you can use. For those of you who attended the managed care in-person trainings, this appendix was not provided for you. I took the maybe 70 or so slides that we reviewed in the in-person trainings, and I essentially turned them into questions that you can use to ask yourself and review the contracts yourselves. But all of you should think about whether you understand what the provisions in the contract mean. If you don't, make sure you learn what those provisions mean. It will be well worth the effort, because every managed care contract has very similar provisions in it. So if you do the work to understand what a provision means in one contract, you'll be able to apply that to another contract as well. And if the contract isn't clear, then you won't be able to rely on that provision if you have a dispute or an issue comes up. You want to make sure that you understand what it means and that it can help you if you have a contractual dispute. Think about the provisions which are going to disadvantage you, what impact they have on you from both a financial, clinical, operational, and a legal perspective. Understand what your responsibilities are and what the plan's responsibilities are. If the contract refers to exhibits and appendices, make sure they have all of them. I looked at a contract just the other day, and it referred to per diem rates in the exhibit. Then when I went to look for the per diem rates, they were not there. So make sure that you have all the rates that are mentioned in the exhibits, so that you have the full contract in front of you. If you don't, go back to the MCO and ask for it. If the contract references policies and procedures, feel free to ask to view those policies and procedures. Many of the plans, if not most of the plans, will have their provider manual available online. If you have questions about their credentialing policy, if you have questions about their utilization review policies, you should be able to access their provider manual and review and see what they say. If there's references to statutes or codes or regulations, make sure you know what those references are to. For example, many of the plans reference New York State's prompt pay law, which requires the plans to pay you within a certain period of time, as well as to pay you interest of 12% for late payments. If there's a reference to it, know where that reference is in the contract. In fact, I would even say go one better. If you have a reference to the prompt pay law, actually have the language of the prompt pay law spelled out in the contract. So if you have a contractual dispute later on, you can actually refer to your contract with your MCO. You don't have to go to the law or the regulation. Think about whether the contract is consistent with any of the other federal or state legal obligations you have, and then lastly, whether the contract reflects sound business judgment. For example, if the contract is not paying you, and not covering your costs of furnishing the services, then that might not be the right type of managed care company contract to participate in. If the contract exposes you to too great a risk, then maybe that is not sound business judgment to engage in that contract. Finally, identify and prioritize issues. This step is critical so that you can figure out for yourself what the most important issues are. I think many of you, when you go through the contract checklist in Appendix A, will actually identify a lot of issues when you go through these contracts, but they're not all at the same level of importance. You need to review them and figure out which are the most critical issues that you essentially cannot afford to proceed with because the risks are just too great or unacceptable. The second area of risk, the yellow risks, are significant issues that you'll want to address before proceeding because they create undesirable risk for you. And then the last bucket are issues that you would like ideally to be addressed before proceeding, but they're not absolutely essential. When you have the discussions with the managed care company, when you negotiate with them, you'll want to make sure that you're right up front with those red critical issues, that if there are 2 or 3 critical issues that you want to address, that you specify what they are to the plan, because these are typically going to be your make or break issues, and you want to make sure that you are clear to the plan what those issues are, and that you're not overwhelming the plan. I can assure you that if you're on the plan side, if you get for example, a red-lined contract back with all the potential issues that you'd like resolved, the red, yellow, and green, and it does not distinguish between what the most important issues are, they may just get frustrated and say, forget about it. We won't contract with this provider, or we just won't make any changes at all. Don't put them into that situation and back them into that corner. Be clear about what the most critical issues are, the 2 or 3 issues that you do want addressed and changed, and work on those. The last phase is the negotiation phase, and it's helpful to think about negotiation not as something that's combative or adversarial, but simply a discussion. This is an opportunity for 2 sides who may see the world slightly differently to have a conversation about how the agreement impacts each of them and how they would like certain provisions changed or adjusted because of the implications to them. In the in-person training session, I talked about a book called Getting TS, which is a book that's been around for probably 30 or 40 years, was written by some Harvard law professors, and it's a great baseline of information for how to negotiate successfully in any field on any contract. They give a great a story in that book about a librarian who has two patrons who are arguing over about how open a window should be. One patron wants the window closed because it's very drafty in the room. The other patron wants it open, wide open, because it's very stuffy in the room. And nothing is satisfying either of them. Not when it's halfway open, not when it's a quarter open, not when it's 3/4 open. Neither of them are pleased with any of those outcomes. The librarian, overhearing this, asks them why they are arguing. You know, what are their interests? Why is neither of them happy with it open or closed? And what does she do? She goes over to an adjacent room and opens that window and closes this one, allowing air to come into the room so it's not as stuffy, but not creating a draft. She found essentially a third way to meet each of those needs. And the Getting to Yes authors emphasize that she would not have been able to do that had she not actually talked to the people and asked them why they wanted the window open or why they wanted the window closed, and then been able to fashion a response that satisfied both. I created another mnemonic. I guess I can't resist. This is the Elvis mnemonic for actually negotiating the contract. The first thing to think about is educating the MCO. Don't assume that they understand your concerns. If there's a provision in the contract based on your review and it impacts you in a negative way, either financially or clinically or some other method, it's harmful to how you provide services, it's going to jeopardize the care that you provide to your clients or your consumers, then educate them and explain to them how that provision impacts you. Do not presume that they understand the impact on your organization. Second, learn from them. So once you voice the issues that certain provisions create, and if they say no, ask them why they're saying no. Truly try to understand by responding with questions to figure out what their issues are, why they've included that provision. Is it something that's related to a mandatory requirement? If they say it is and you're not so sure, this is a chance that you can go back to the RFQ and see whether it really is a mandatory requirement that they don't have any flexibility. If they give you another operational reason for why they can't adjust or change something, learn from that and understand what the implications are for them. Think about whether they can offer you any other options for how you can achieve your goal without having the same impact on them. Think about voicing options. What are the possible options for adjusting the contract that can satisfy both your interest and the plan's interest? And then the I is insist that the resulting provisions are based upon some objective standard. Now, that objective standard may be an external benchmark, but it can also be a principle that you hold dear. For example, if you have an indemnification clause in the agreement and it only protects the plan, in other words, you are indemnifying the plan for anything that you've done willfully or negligently that results in a claim or expense to them, and you're protecting them, why isn't the provision bilateral or mutual? Why doesn't it run both ways? You can insist on the principle of fairness that if the indemnification clause protects them, it should also be a way to protect you for their negligence or their willful misconduct under the contract. And then lastly, emphasize over and over again that you intend this to be an ongoing relationship, that this is not just for one time or 1 year, that this is a continuing relationship and that it's important to you, and that you want the contract to reflect good, fair, equitable terms so that you can continue to contract with the plan in the future. Once you make your attempts to negotiate, and if they don't all go your way, this is the time to think about whether you want to move forward or whether you want to make some other adjustments. If you do not resolve all your most important critical issues to your satisfaction, then you have some hard thinking to do. You might want to think about whether this particular MCO contract is essential to your operations. If there are many MCOs offered within your county for your services, there's no mandate that you contract with every MCO. You may decide that you only want to contract with a subset of those MCOs. Now, clearly this has financial implications for you, because that means that if patients are referred to you that are not covered, that you're in a plan that you're not networked with, then you may not be able to serve them. They may need to go somebody else to another provider who is a participant provider in that plan's network. On the other hand, if you can't reach a fair agreement with a plan and it would cost you more money, then maybe it's not worth contracting with that particular plan. So think about evaluating the risks of contracting in light of those critical issues and whether they outweigh the risks of not contracting with the MCO. You might also consider whether you can terminate the contract early in the event that the financial or legal harm that you're concerned about becomes too great or actually comes to be. Maybe it's a potential risk that you think might happen in the future, and then when it happens, you'll want the ability to terminate the contract. So what's the length of the contract? What's the termination clause say? Does it allow you to terminate without cause with a certain number of days notice? And is that notice period, are you comfortable with that minimum amount of notice? And then lastly, think about if you can't negotiate the contract to your satisfaction, are there other options that you can use to achieve a better outcome? Your state, OMH and OASAS, if plans are not meeting their obligations, then they may be able to assist you in intervening to get a provision changed so that the plan complies with their obligations. Your state and professional trade associations, they also may be able to play some role in assisting you. And then lastly, there are many consultants, agents, lawyers that are happy to be your agent in those negotiations with the plans that may offer you the ability to achieve a better outcome. Finally, my final thoughts is to think about your position in the marketplace as you move to a Medicaid managed care market. This is a market with buyers and sellers. It's a marketplace that's supposed to be that's supposed to represent a situation where now providers have the ability to negotiate reimbursement rates with payers. Now, despite the protections in the first couple of years, at some point you will move to a market where you will be competing perhaps against other similar organizations and agencies, where you will be competing on price and value and outcomes, and you'll want to be strong in that marketplace. So it's important to think about now, what are your strengths and weaknesses in the context of a Medicaid managed care marketplace? Who are your competitors? Can you compete with them on the basis of value? Could you go to a plan and say that you provide better services and better outcomes than another provider within your county? Can you show to the plan, prove to the plan that you can save them money because you can reduce hospitalizations or ER visits more effectively because you have an integrated care model that combines physical and primary care? What organizational strategies can you use to increase your leverage and your ability to compete on value? Is it worth pursuing certain collaborations with other types of providers? If you don't have a collaboration with a primary care provider, maybe that's something that you want to consider. If you want to collaborate with other like providers and forming an integrated network, a network that does back office services like an MSO, or whether you want to form an integrated practice network that's clinically or financially integrated and have the network be the contracting agent with the managed care company. You can think about those options. At the end of the day, the onus is really going to be on you to initiate those conversations with the MCOs, to discuss with them about how you want to be paid in a way that supports quality delivery of services and lowers the overall cost to the MCO for taking care of the population which they're obligated to take care of. These are the things that you should be thinking about now to position yourself in a place of strength in these discussions and negotiations with managed care companies. Why don't I stop here and see if any questions have come in before going on to the appendices.
So Adam, I'm going to let you take a deep breath. I want to thank you for all this, incredible, just thoughtful and well laid out process for kind of negotiating contracts and the issues you have to think through with contracting. So we've gotten a whole number of questions that have come in over your talk. I'm going to start with a couple questions that we can answer on this side that are either MCTAC related or relate back to our frequently asked questions from OMH and OASAS. And then I'll dive into the questions for you, but figure give you a chance to take a breath and grab a quick sip of water. So first, somebody wrote in, I submitted a readiness assessment survey online last week, but didn't receive any type of confirmation of submission. How do I know it was submitted appropriately? If you shoot an email to mctac.info@nyu.edu with your agency name, we can track that down for you and get back to you about that assessment. So any of those kinds of things, just shoot an email to mctac.info.edu. So that is that. And then we got a couple other questions relating to they relate back to questions we actually got at the kickoff, so the formal answers are there. What Americans with disability rules apply under the Medicaid managed care? And if you refer back to our frequently asked questions, which is on our website, there's a whole very, very detailed answer from OMH and OASAS and DOH on that. So just refer back to our FAQs. It's on our website. And then if MCOs are not mandated to contract with the providers, will plans still give other providers contract? The question here was around the 5-person rule. So I'm just going to read this because it comes directly from the OMH language. I want to be real clear. An MCO, both mainstream and HARP, is required to offer contracts to behavioral health programs, including both OMH and OASAS, serving 5 or more of its enrollees. For programs licensed by OMH, the requirement is program specific, i.e., all of the agency's mental health clinics, but not necessarily its PROS program and CDTs unless each of them also served 5 or more of its enrollees. An MCO can contract with all of an agency's mental health programs or even one or more of its programs. More of its programs did not serve 5 or more of the MCO enrollees. For agencies with 1 or more licenses from OASAS and one of its programs service 5 or more enrollees of an MCO, the MCO is required to put all of the agency's OASAS programs in its networks. Plans may offer contracts to providers other than those that are mandated. So plans can offer contracts to providers that are not mandated, but they are required to provide contracts for OASAS. If anywhere in the agency they have more than 5 clients, they have to offer to all programs, and OMH, if they have more than 5 clients in any one of the program's particular program categories, so clinics or PROS or CDT or any of those kinds of things, they have to offer that contract. But for the official language, go to our website at MCTAC.org, and on there very prominently displayed is our contracting, our kickoff FAQs, and the formal answer is in the kickoff FAQs. At this time, another question came in with referrals for lawyers, agents who can help with negotiating contracts. At this point, we don't have a list of kind of vendors to refer to. Obviously, Adam provides that services and others provide those services as well. If you reach out to us, we are in the process of kind of developing a list of consultants and appropriate vendors for that kind of thing. But it's not ready yet, but we'll do a public announcement when it is. Okay. So I'm going to dive in to the questions for Adam. The first one is, I work in a hospital setting and we have contracts with many of the participating insurance companies. Is there additional work that needs to be done to existing contracts to be able to move forward once this new system rolls out?
Great question. The answer is yes. All the mainstream plans that now have to incorporate the behavioral health benefit will be modifying their contracts with providers. I talked to a few. I understand that they're doing it right now. The reason is because under the RFQ, there are certain types of services that they must provide, certain obligations that they must adhere to, and they'll want to roll those requirements down to you. They may need to add payment or reimbursement rates to your contract so that they meet the managed care RFQ requirements for certain payment minimums, payment protections. So I would expect to see that if you're already contracted, expect to receive an amendment that amends your existing contracts to accommodate the new behavioral health requirements under the RFQ.
Great. The next question came in about the book that Adam mentioned, and Adam actually responded in the chat box, but the answer to that question is Getting to Yes. So the name of the book that Adam was talking about was Getting to Yes on negotiating practices. Next question is, are there contracting considerations for single case agreements?
What does the question mean?
The question was, are there contracting considerations for single case agreements?
I'm not sure they would have specific considerations that are any different than the considerations that were already discussed. It's a different payment method, and under the RFQ, there's actually some single case agreement language discussed, but it's a one-off situation. Typically, when you don't have a contract with an MCO because you're not in the network or it involves a service that's not typically required, then the plan will strike a single case agreement with you just for that particular patient. But it's usually done entirely separate.
Okay, very good. And then a question came in around competition and marketing. Is this about MCOs agreeing to contract with us or about getting referrals from MCOs and good reimbursement rates once we're contracted? Is there a reason that MCOs would not want to contract with us?
Yes, there could be reasons why the MCO doesn't want to contract with you. It could be because they don't feel they feel that their costs are going to be higher with you. Perhaps they think that there's another provider within your county that they can contract with, assuming that the RFQ requirements don't require them to contract with you. Maybe there's a lower cost organization that provides the same or similar services. Maybe they've done and run the numbers, and maybe they found that this other provider manages the overall cost better or prevents hospitalization or some other aspect of care that results in higher quality and maybe earns them quality incentives, money that was withheld. There can be a variety of reasons. Maybe they feel that limiting access is good, that it reduces total cost. I hope they don't think about it that way, but certainly you can imagine a situation that if they have only a limited number of providers, then that may reduce the total number of claims that are submitted by providers for services. So there could be a variety of reasons that a plan has not to contract with a particular provider, everything from credentialing and licensure and technical requirements for whether they think they're qualified to render the service to issues related to reimbursement rates and outcomes.
Fantastic. And just to highlight, on our MCTAC.org website, we all have both the FAQs, which lay out the 5-client rule, as well as the slides from those kickoff events, which lay out kind of the conditions under which managed care has to contract with you. So I would highlight for the questioner to go back and look at those things as well, which will give you a good lay of the land. One question was the list of MCOs in my area. So OMH and OASAS haven't formally designated the MCOs in any of the areas. They're very close in New York City, but outside New York City, they haven't even done the RFQ process yet. So that notice isn't officially out, but what I would do is look at the providers, the managed care companies that are providing physical healthcare services to Medicaid recipients in your area, and that's a pretty good bet of kind of who the providers will be, who the MCOs will be for your county if you want to start to look at that now. Next, current. Yeah,
actually, Andrew, I would just add to that. There's a page on the OMH, not on the OMH, I think on the DOH website, where you can actually go to, and it will list out each of the plans that are covering different counties in the state of New York for the physical health benefits. So you can actually see what plans are offering the physical health benefit, and it's likely that many of them will also be offering the behavioral health benefit now. That will now be required. So probably be many of those same players, the same managed care plans, if you want to see who's providing, who you're likely going to be contracting with.
Okay. And the next question that came in, actually, I'm going to refer back to OMH and OASAS because I'm not actually sure the answer of this. Current payments for Medicaid are reduced based on utilization thresholds, so once you hit 25 or 50 or more. Will this system remain with the MCOs over the next 2 years? I'm going to refer that back. I don't think it was a question in the FAQs, but if it's not, we'll send it to OMH and OASAS and get an answer to folks on that, and we'll update the FAQs. What can providers expect in terms of potential auditing from the MCOs, Adam?
It depends on the MCO, but they certainly will have the rights to audit you for various reasons, particularly those that relate to reimbursements for services, to ensure that there's documentation to support the claims that you submit, as well as for the quality measures that they're evaluated on. Many of the plans will send out people so that they can obtain the information that they're required to submit to the state. Now, hopefully you won't have all 8 or so plans visiting you at one time. Hopefully that it will be a situation where you can take one by one. But they are entitled to reasonable access to information. Again, reasonable access, so presumably that means notifying you in advance, allowing you to schedule them for when you don't have another plan already visiting that particular day, for not interrupting and interfering with your operations. But you have to sort of work it out and negotiate it with the plan so that it's convenient. They are entitled to come do some auditing, but it should be reasonable and it shouldn't interfere with your operations.
Fantastic. And then we got a question from somebody who came to the live training. In light of the learnings and the ins and outs of contracting during the live training, I'm getting pushback from clinicians as I, the billing specialist, attempt to tighten up how and who is providing services under which insurances. since they are questioning if they are mandated to code their own sessions, or can the billing department do it or a system automate the codes based on keywords. I would just refer folks to this. We're going to be doing a whole series of trainings on revenue cycle management. So I would highlight that issue. It's going to be part of that training to talk about kind of, for clinicians, what do they need to do? For you as a billing coding specialist, what do you need to do? And those kinds of things as well. So I'd wait for that series to come out sometime in the next month or so, and then focus on that. Adam, I don't know if you have anything to add to that.
Yeah, this is probably going to be one of the most operationally difficult things for folks who have not already been doing managed care contracts in the past, is that each of the plans have their own set of billing instructions and billing rules. They're not necessarily consistent, so I would encourage you to take advantage of all the trainings that are provided by them, and also make sure that you use that forum for asking them questions if you've had encountered difficulty. Internally, it can be also a challenge because the practitioners who are actually determining what codes are, what the codes are on the claims, and documenting the services that have been provided, they'll need to document in a way that satisfies the plan's requirements, and it could vary by plan. So there's a lot of education that has to go on in this process that's going to take some time and there's a pretty steep learning curve as well.
Very good. If our facility is already contracted with a managed care company for substance use services, will we need to renegotiate the rates to get the Medicaid rates once this transition starts, or will they automatically pay us at the Medicaid APG rate?
I would reach out to them, and don't assume that anything is going to be automatically done. I heard from a provider in New York State where the plan didn't even realize that they were licensed or certified by one of the agencies, and it was not even included in the covered services that they had contract that they had sent into the plan. So reach out proactively to the plan and ask for an amendment to your contract so that it covers all the services that you provide at the contractually appropriate rates, the RFQ rates that are in the contract, and do not wait for them to contact you.
Sorry about that. Very good. Okay, the five client rule came up. I just want to refer people back to those FAQs again, because that's going to be critically important, just because that lays out the official OMH and OASAS response. Children in Medicaid managed care may have primary care coverage in a commercial plan through a parent. Medicaid then pays any deductibles and coinsurance. If the commercial payer denies care based on medical necessity, how do you then bill Medicaid for managed care?
That's going to be one of the specific questions you need to ask each of the individual plans, what you have to show. You have to show that denial to them before you can turn around and bill Medicaid. Will that type of claim be paid, and any other requirements? It's not going to be found in the, I can't tell you what the answer is.
Okay, very good. Does anyone know if any MCOs have contracted with opioid treatment providers in New York State already? I believe some have, and they will be required to contract with all the opioid treatment providers in New York State starting in the Medicaid managed care transition. But that official document is in the FAQs as well, but just to double check, but I'm fairly certain that people have to contract with all the opioid treatment providers when we go live. How's behavioral health driven enrollment, OMH and OASAS services transitioning to Medicaid managed being trended? I'm not sure exactly what this question is getting at. How is the behavioral health driven enrollment, OMH and OASAS services transitioning to Medicaid managed care? Okay. Do you have information regarding the most recent implementation timeline and deadlines to enter into networks? So the most recent notice came out in the last couple of weeks. We've published it on our MCTAC website, so you can go to mctac.info. It's also on the OMH and OASAS, and I believe the DOH websites as well. And then the next question is, as an OASAS prevention provider that does not currently bill Medicaid, are we able to contract with MCOs for prevention services under the new system?
What I would encourage you to do is to look over the required services that have to be provided under the contract that the plan pays for, match them up to what you provide. If there's a match there, then certainly you'd want to reach out to the plan and obtain a contract so that you can be part of their network.
Okay. And another question came in regarding, you had suggested that agencies should investigate the MCO's financial stability and viability. And the questioner just wanted to know what suggestions you had for how does one go about doing that.
Well, I would start with Google, like everybody starts with nowadays, but you should be able to find things from your state insurance agency or commissioner. And every state across the country, insurance commissioners collect information from plans about their reserves and their financial situation, if not on an annual basis, sometimes even on a quarterly basis. You should be able to contact the insurance agency in New York State and ask for specific information about the financial position of any of the plans in the state, access information that way. This information, you might even be able to ask the plans directly. There may be obligations imposed upon them for disclosing information for individuals that ask, but I think you could start with your state insurance commissioner first to get access to this kind of information. Are there other questions?
Sorry, Adam, I had you on mute, but I was reading the question very well. The next question was, I work for an OASAS for-profit agency that obtains the majority of their referrals via court mandate. How will this work for contracting with MCOs?
So the court-mandated services are sort of a technical aspect of the contract of the RFQ. I would encourage you to look at those provisions about the obligations for situations for when the plan has to pay and when the provider has to, continue to bill the state directly. Look over those requirements to determine whether if the plan has the obligation to pay, then you might need to get a contract with the plan. But you need to look over that provision of the contract carefully.
Very good. There's a regulatory scheme for documentation mandated by the state in residential programs that bill Medicaid. Do you think that MCOs will adopt these, or do you think they will create their own mandated documentation rules?
In my experience, plans have not necessarily taken all the rules that apply in the fee-for-service program, including the documentation requirements, and used those in their own managed care programs. So I think that it would be highly suggestive of what a plan might do, but not necessarily the rules that would apply for that particular plan. There are many references within the RFQ for states, for plans actually following clinical standards and different types of guidelines that are issued by OMH and OASAS. I'm not sure documentation is going to be one of those required guidelines that they have to follow. Plans are typically given broad discretion to identify and impose particular billing and documentation requirements. So this is going to have to be a question that goes back to the individual plans to see what they require.
Great. Do managed care companies have to pay for services to patients with insurance? Fee-for-service patients, will the rates be similar?
Do plans have to pay for
commercial rates?
Right. So under the RFQ, there's no mandate for how much you get paid for commercial patients. So if the plan has a Medicaid managed care line of business and it also has a commercial line of business, those will have different rates associated with them. The Medicaid rates will be protected under the RFQ. They have to be at least fee-for-service. But on the commercial side, they can be whatever the plan and you negotiate. There's a lot more flexibility for both parties. I've heard historically that the commercial rates are not as generous as the Medicaid fee-for-service rates, so this is likely going to be a point of contention or a point of negotiation, but you'll want to make sure that that's addressed. As of right now, there's no prohibition of an all products clause in the managed care contracts. In other words, the plan can essentially force you to accept their commercial line of business and their Medicaid line of business or any other line of business that they have, be it Medicare or some other employer-based line of business, and you can't pick and choose just to participate in one. In an ideal situation, you would have a contractual requirement in the RFQ that prohibits the plan from sort of bullying you to take all their business lines and allow you to opt out of the commercial or other lines of business and accept just the Medicaid line of business. But right now you don't have those protections under the RFQ.
Okay. We're also nearing the end of the questions, so if folks have any additional questions, now would be the time to chat them in so we can make sure that we cover them before we wrap up. One other additional question on the MCTAC side of things. The deadline's posted on the MCTAC website. Refer to HARP exclusively. Where on your website is the information for all providers? it's covering only OMH and OASAS providers and the extent of transition to managed care. The soft rollout in New York City is the enrollment of individuals in the HARP program specifically, but they will be enrolled into their regular managed care programs as well as we move forward. So other questions that have come in, I'm going to give folks another minute or so to add in any additional questions, and then we'll wrap up. But while we're doing that, waiting for any additional questions to come in, I just really want to thank all of you for joining today, as well as thanking Adam for taking the time to join us today and really provide a lot of really very, very helpful information to folks around contracting. I also want to highlight that this webinar will be posted. It has been recorded and will be posted on our website in the next couple days. The FAQs from the state kickoff events are already up and live on our website and prominently featured, so it should be pretty easy to find, as are the PowerPoint slides from those kickoff events, which will give you a lot more detail in terms of kind of the structure for the kind of regulations behind all of this. And also just to highlight that Adam, again, one more time, Adam's video presentation of his live, I don't want to say performance, but live presentation is up on our website, where he goes into a lot more detail on what he discussed today. So I don't see any additional questions coming in now. So with that, I want to just take the opportunity to thank Adam one more time for joining us. And also to thank all of you, both to those of you who came to both the in-person events as well as today, and also for those of you who just came today. Hopefully you found this helpful. There'll be a feedback questionnaire at the end of this. Please give us your feedback. We take the feedback very, very seriously in terms of kind of additional programming and also in terms of making improvements to that. So with that, I want to just say thank you again to Adam for joining us today, and really look forward to working with all of you in the weeks and months ahead. Please keep an eye out for all our website postings and our new training postings. There'll be quite a few coming up in the next couple weeks. So thanks again, Adam, and thanks to everybody on the line as well.
Thank you.
All right, that'll conclude our webinar today. Thanks so much, everybody. Bye-bye.